Ruth Jackson Orthopedic Society.
This meeting is being recorded.
Hi, good evening, everyone. My name is Julie Samora. I'm the current president of the Ruth Jackson Orthopedic Society, and it gives me great pleasure to present the first journal club that is a collaboration between Speak Up Ortho and RJOS. We could not do this without our staff at RJOS. Deborah Meyer and Carrie Mink are invaluable, so thank you for getting this ready. I appreciate all of the panelists this evening. Lisa, Cannada has really brought together an amazing group of diverse individuals with excellent suggestions. We are tackling critical topics tonight, and I'm looking forward to the discussion. Dr. Cannada, thank you for bringing us together.
Thank you, Dr. Samora. Thank you to the Ruth Jackson Orthopedic Society. I would like to welcome you tonight to the first Ruth Jackson Orthopedic Society and Speak Up Ortho Journal Club. I really appreciate the sponsoring in this event, and I hope you enjoy the session. Julie Samora, the current RJOS president, will be my co-host. We are joined by our orthopedic surgery discussants. Sandy Klein from St. Louis, Ron Navarro from Los Angeles, Lattisha Bilbrew from Atlanta, Arianna Gianakos from Boston, and Jennifer Weiss from Los Angeles. Speak Up Ortho was created to increase awareness of the harassment, bullying, abuse, and marginalization in orthopedic surgery. We hope to improve the culture, which may ultimately improve our goal of improving diversity in our field. Through this social media platform, we have collected over 400 narratives. We have garnered increasing support through our friends and followers. I am going to read just 3 of these narratives. They are not just limited to women, and they are not just limited to residents or students. They include stories from men and the people from all levels: medical students, residents, fellows, attendings just out in practice, attendings 20 years and more in practice. And they also include stories by some of our advanced practice providers. I will read just 3 of these, and then we will get started. The first one, I became unexpectedly pregnant during residency. And I told my fellow residents, one of my uppers made comments about the group about picking up my slack while on maternity leave, ending with the statement, I will bring a wire hanger to work tomorrow. You know what to do. In another story, the sexual harassment, stalking, and discrimination was so rampant through my training by both fellow residents and attendings that I was literally afraid to go to work. I could barely get out of bed most mornings. I carried a disposable 11 blade with me everywhere I went for that moment when I decided that I truly couldn't carry on. I still have that 11 blade as a reminder of the hell I survived. I am a male orthopedic surgeon. Even writing this makes me uncomfortable. But I have an attending male surgeon who constantly makes me feel uncomfortable. He touches me when people are not looking. He comments about my body. He sends me photos of inappropriate sexual things. This person is in charge of me, and I do not know how to deal with handling this, as I am scared I will lose my job and he will come after my reputation. The effect of these behaviors affects one's mind, body, and soul. Unless you experience them, you cannot imagine the way one feels. The microaggressions become macroaggressions. Overall, the toll affects one's mental health and leads to a variety of emotions. These include anxiety and many others. Continued behaviors, which we know occur from the literature, lead to depression and burnout. In addition, at the extreme, one may consider suicide, as demonstrated in the narrative. The days of see no evil, hear no evil, and speak no evil are over. We need to have zero tolerance for these behaviors and develop methods for reporting without fear of retaliation and actionable consequences for our perpetrators. There should be zero tolerance for this behavior. Over the past 2 years, there have been several crucial articles on these topics in orthopedic surgery, and quite frankly, the results are startling. These 5 articles were selected to begin important and sometimes difficult conversations. A journal club kit will be made available to all residency programs and practices that want it. We hope this model will encourage frank discussions on these topics and lead to improvement. The format tonight with our orthopedic discussants will be a 5 to 6 minute summary of the articles and a discussion led by Julie or myself on key take-home points. We will provide ample opportunity for questions, comments, and suggestions to make a difference in our field. We hope you enjoy this Journal Club webinar. Our first article will be discussed by Sandy Klein.
Thanks, Lisa, and thanks for having me as part of this panel. Welcome everyone to the Journal Club. And the first article is titled, "What proportion of women orthopedic surgeons report having been sexually harassed during residency training?" And this was a survey study by Whicker et al. Go ahead and advance the slide. So in this article, go back one if you could, Lisa, sorry. In this article, the authors basically seek to further understand the proportion of women who experience sexual harassment during training. So, they wanted to identify whether there was a time in residency, meaning did it happen more often years ago and less frequently now? And also, was there a difference in location geographically in the US? As part of this survey, reporting of harassment was also investigated. Next slide.
Is this the one?
Go back one. Sorry. I don't know why it's.
I know, I don't.
There you go.
One more.
This one. No, this is good. Basically, before we kind of talk about the methods and the results, I wanted to put up a slide that defines sexual harassment because I think this is important to understand. Sexual harassment is essentially harassment because of that person's sex. Harassment can include unwelcome sexual advances, requests for sexual favors, verbal, physical harassment of a sexual nature. But in addition to that, it can include offensive remarks about a person's sex, specifically harassing a woman by making offensive comments about women in general. And I think that's helpful to understand because that may be an aspect of sexual harassment that we sometimes overlook. Next slide. So this was a survey study distributed to members of RJOS, and it essentially consisted of a previously established workplace harassment survey. And then they added questions so that we could understand resident versus practicing surgeon and time and location of training. Next slide. So in this study, 68% reported sexual harassment during training, no difference between current and past trainees, and no geographic differences. Obscene images, unwanted touching, unwanted invitations from male residents and male faculty were the most common types of harassment, and only 15% of these respondents had reported. So I think the most important takeaway from this article is that look around the women in your group, fellow surgeons, your partners, your colleagues, 2/3 have experienced sexual harassment. That's a huge number. And they cited retaliation and pointlessness as the reasons they didn't report, which implies that the workplace really is hostile or unsafe for victims. No geographic differences also means that no program is free from this problem. I think it's happening everywhere. And that's another important point that I got out of this article. Lisa, I don't know, do you want to go through the questions at this point?
Yeah, let's go through some questions. You were a program director. Are you surprised at the statistic of 68% of respondents reporting they had been sexually harassed during their residency training?
I think I can honestly say I wasn't surprised. The number didn't shock me. I think it's only because I've seen enough of it, heard about enough of it, that I expected it to be a high number.
And have you ever reported an event?
I've never reported an event of sexual harassment. But I think if I look back on my training and my career as a whole, I've definitely been a bystander. But it hasn't always been safe to speak up. So, I haven't ever reported.
What do you think we can do to make it safer?
That's a tough question, because basically safety is about the victim feeling like it is not going to hurt them to report it. So we have to have an environment that really pushes back on the idea of retaliation or protecting the perpetrator. It's got to be zero tolerance, like you said, and I think we're not there. I mean, it's going to take a lot of effort, and it has to be intentional.
Do you think the reporting should be an anonymous type of reporting, or what do you think will make people report these events so that we don't have to open up this article and read some of these terrible experiences?
I think ultimately, if you're a victim of sexual harassment, being able to report it, you may prefer the anonymous reporting, but I think it's so important for you to talk to people and feel the support of your colleagues, your leadership, to understand that it is a safe environment for you and nothing's going to happen to you. That when you turn it into an anonymous reporting system, yeah, it might help hide your identity to some degree, but in an environment where there are very few women, sometimes they're going to know it's you anyway. I mean, we just have to really be protective of the victim, and focus on our support of them.
And how do you think it affects their residency training? Should we give them time off, or how can you help a resident in this situation?
Well, I think in any situation of harassment, you have to provide your unconditional support. You can't imply that it's their fault. You can't defend the perpetrator. You have to make it a safe environment so that they do feel like some action's going to be taken. And you got to live by that zero tolerance rule. I think that when this happens to somebody in residency, it can easily turn their residency training into something that they just have to get through or survive. And that's not the best way to train orthopedic surgeons. That's not a way to ensure their success if they're just trying to get through every day and stay safe.
I agree. And if events are not reported, how does that affect the overall culture of the residency program? What does the culture become?
Yeah, I think, it kind of depends. The idea, can one bad apple spoil the whole, bunch? I don't necessarily think that it automatically leads to a culture where people are harassing other people without, any regard for just normal decency. So, I think what happens is it becomes a place where you kind of know that, number one, you're not going to be heard or protected if you are a victim of some sort of harassment. And then I think it can spill over into things beyond sexual harassment, like discrimination, gender bias, racial bias, microaggressions, and more subtle behaviors that, permeate the workplace.
Hey, Sandy, I have a question for you from the chat, Lisa.
Great.
A woman texts or puts in the chat, as a medical student about to apply to residency, what questions should we ask the interviewers to get a sense of the atmosphere of these institutions?
I think one thing that you could ask, and I kind of came up with this, honestly, as I was going through this for medical students, not just at a medical school level, but you could do this at a residency level. Just what's your policy? If somebody reports sexual harassment, what protocols are in place to address that? And if they don't have protocols, or they can't answer, or no policy is in place, or there may be a policy, but the person you're talking to doesn't know it, that does tell you something about how important they think it is, or how much it's prioritized in that organization. I mean, theoretically, everybody should know what the process is if they witness harassment or if they're a victim of harassment themselves. So we should be able to tell interviewees that if asked.
You're right.
So I want to make one more statement. I'm so sorry. I just love this. Rena Jane shared this. On my first day as an intern, our internship director took all of us new docs aside and told us that sexual harassment by anyone is not tolerated. This was 1992 in Toronto. He simply said, no exceptions, no defense, nothing. Just don't do it ever. 30 years later, I realized that this culture comes from the top. Pretty powerful.
Totally. I mean, I could not agree more with Rena. That's what a lot of this stuff comes down to, is this has to come from the top. And when he said no exceptions, no defense, nothing, that's the zero tolerance policy. And as long as he followed up on that, as long as that was a reality, then that's the way to do it.
That is great. Thank you, Rena, for sharing that. And it is true. The culture of a workplace is determined by the leaders at the top. Thank you, Sandy, for your wonderful summary of that article. We are going to move on to the next article. Again, we'll have lots of time for discussion. Our next Journal Club article, in this, the statistics just blew my mind. What is the prevalence of burnout, depression, and substance abuse among orthopedic surgery residents, and what are the risk factors? And this was a research study from the Collaborative Orthopedic Education Research Group's survey study, and Ron Navarro will be covering it. Go ahead, Ron.
Hi, Lisa. Thank you for inviting me, you and Julie. I consider you dear friends, and these are important topics, and we should not avoid difficult conversations like these. So thank you for putting this forward. In this study put forth by the authors that Lisa described, and one is a friend of mine, Brett Ponce, out of Alabama, they sought to report the proportion of orthopedic residents who report symptoms of burnout and depression. They also wanted to look at factors that are independently associated with the orthopedic resident reporting emotional exhaustion, depersonalization, low personal accomplishment, and depression. They wanted to look at the proportion of orthopedic residents who report hazardous alcohol or drug use, and look at factors that are independently associated with those behaviors as well. Next slide. So just real quickly, the definition of burnout per the paper, and hopefully most accept this, it's a syndrome resulting from chronic workplace stress that has not been successfully managed. It's characterized by three major dimensions: feelings of energy depletion or exhaustion, increased mental distance from one's job, or feelings of negativism or cynicism related to one's job, and reduced professional efficacy. Burnout is more common in physicians than in nearly all other professions in the United States, and it's steadily increasing, with more than 50% of physicians reporting at least one symptom of burnout. Burnout may contribute to detriments not only to personal health, but also to patient care, certainly, and safety and overall healthcare costs. Next slide, please. So they took and surveyed all the orthopedic programs in the country to have residents participate in a 34-question internet-based anonymous survey. 661 residents completed the survey. That's out of over there's close to over 1,100 orthopedic residents in America, and so 46 out of the 164 total orthopedic residency programs were represented. Their responses were evenly distributed among training years, and 83% 83% of the residents were men, 15% were women, and 1% preferred not to provide a gender. The survey asked about various things like demographics, educational debt, sleep and work habits, perceived peer or program support, substance use, and validated instruments were used to assess burnout, depression, and hazardous alcohol use, and they're listed there. Next slide. The burnout was reported in 52% of the residents, 342 out of 661. And I wanted to go back and say that the 661 residents answering a 34-question survey when they're incredibly busy shows how important this topic is. Some of the factors that were associated were high emotional exhaustion and depersonalization, as well as low personal accomplishment. And some of the factors that brought on the burnout were early training years 1 and 2 more often than not, unmanageable work volume, inability to attend health maintenance appointments, a lack of exercise, lack of program support, and lack of co-resident support. A lot of us are just getting, post-traumatic stress, saying that was my residency. And so 13% of the residents had positive screening results for depression, and exceeding duty work hour restrictions and lack of program support were key factors. 61% of the residents met the criteria for hazardous alcohol use, being a man, being Asian, single or divorced, marital status, night were some of the factors, and 7% of the residents reported using recreational drugs in the previous year. Single or divorced marital status were contributing factors. Next slide. I think it's my last. So a lack of wellness among orthopedic surgery residents is incredibly troubling. Most of the associated risk factors are potentially modifiable, and those are some of the program goals of the article and the folks who were working on this. Education of residents on burnout, focus on work volume, protecting access to health maintenance, letting people go to their doctor's appointments, nurturing those who are in their early years of training, and remaining acutely aware of the risk of substance abuse are critical. Trainees should strive to encourage peer support, talk to one another, cultivate personal responsibility, and advocate for themselves or peers in an open way when faced with challenges. Leaders should foster an environment in which admitting symptoms of burnout is not seen as a weakness or failure.
Thank you, Ron. I was just shocked when I read this article about the, burnout and well-being, and 61% met the criteria for hazardous alcohol consumption. That's really scary. So why do you think this occurs in over half of the residents?
I think it probably reflects a stigma and lack of support by training programs, because 50% of the physicians report hesitance to seek mental health care, and they're fearing medical licensure limitations. That's one big thing. I think there's a culture that deters self-care, and that's dangerous. It has to be addressed by leadership, just like one of our attendees said. If you do it right away and make it clear that you can say these things and talk about these things, it makes it okay. Some recent orthopedic research has suggested some lack of ownership by some of the residents in the residency programs, a possible generational stereotype, a hindrance to education, and rather than acknowledging a need to consider or address burnout and well-being.
So Ron, what do you think are some ways to cope with burnout? If someone comes to you and you say you administer the survey because it's readily available from this journal club, this is important to talk about, and we don't want to push it under the rug. It's kind of like, we need to bring this out in the open. What are some ways you can cope with burnout?
Yeah, I think I've read about this, and this is kind of framed in the scenario where you can't quit the job. A resident, it's hard for them to quit the job. Anybody should probably pull the and-on cord and say, I'm out if it's too much. But this is just with the perception that, it's pretty hard to walk away from a orthopedic residency program that you've worked all your life to achieve. So number one, you have to reframe your mindset and consider the role you're burned out from, and remind yourself why you started. put the why back in what you do. Secondly, make time for self-care. What does that mean? It mean, days off, exercise, appropriate sleep. Sleep is critical. Thirdly, ask for help. If you're having severe problems, you've got to ask for help, and hopefully it starts from the top and you have leadership that supports you. We've discussed this a lot already. Maintain a social life. Don't become cloistered all by yourself. I think loneliness can contribute to that. And also set boundaries. So many of us are such type A's that we want to always keep taking on more tasks. And I often tell a lot of med students, it's important to have lines on your CV, but they're just one line on your CV. And sometimes you don't need one more line on your CV. You need your sanity. So I think those are some of the big ways to cope with it.
So Ron, another statistic that came up, and that was about the criteria for hazardous alcohol consumption. In interviews for residency and even on the in-training, it's been asked what you would do if a colleague came to work under the influence. Well, let's answer that question. Can you give me an answer?
Yeah, I think we all have a responsibility to protect patients. It's just, inherent and sort of in our Hippocratic oath. And separately, we have to protect our colleagues, potentially from themselves and others. Most of us in our work agreements, we've signed agreements around workplace behaviors and the concept of alerting supervisors when these types of scenarios might occur. That oath, we have a fiduciary responsibility as well. We can feel compelled to shield our colleagues, and probably the best act is to get them help. It's one thing to say, hey, I'm going to take you aside and hopefully nobody will find out. But I think it's probably more important to disclose both to them and to others so that they can get help. And hopefully there's a supportive environment for them, a leadership that's supportive to help them get help if it's certainly if it's a recurrent sort of behavior.
And, how ultimately do you think patient care is affected? Because the orthopedic resident is often the face of the practice and people don't realize it. Your resident is the first person a patient and their family may see. So how do you think patient care is affected by these statistics?
Yeah, we care about residents, and beyond that, these issues have profound impact, as you say, on patient care safety and really even healthcare costs. So I found one study that showed that 70% of errors committed by surgeons were due to symptoms of burnout and depression, not honest mistakes like, oh, wow, I thought I was doing the right thing. They actually admitted that that other things in their life, like burnout and depression, were having such a profound effect on them that they committed an error. And those errors, they affect the patients we care for, and ultimately healthcare costs. It's not about the money, but healthcare in America is sometimes it's taxing all Americans. And so if we have avoidable or mitigatable reasons for healthcare costs, redo surgeries, et cetera, we should do everything we can to manage that. And by helping these residents not have burnout, not commit mistakes, it's a part of that overarching effort.
Thank you. And thank you for your excellent discussion of this article. I'm going to turn it over to Julie now for the next article, and Lattisha to present it. And I will control the screen.
This is all Dr. Bilbrew.
All right. Thank you, Julie. Thank you, Lisa, for having me on. I thought this was a great article, and I'm really looking forward to the discussion on it. So, did my video start? I think it did. So we've all heard the term microaggression. It was actually first coined in the 1970s, and we know that it can have very damaging effects, leading to the compromised quality of care, as well as, of course, psychological distress. Women and underrepresented minorities are going to be the most common targets of microaggressions in the workplace. In this study, the author was seeking to determine if microaggressions are experienced by female orthopedic surgeons and how prevalent they are. Next slide. So microaggressions are defined as verbal, nonverbal, and or environmental slights, snubs, or insults that are either intentional or most often unintentional, conveying a hostile, derogatory, or negative message towards a targeted person based on their membership in a structurally oppressed social group. It is, of course, rooted in implicit or explicit prejudice and other stereotypes such as sexuality, race, ethnicity, gender, religious beliefs, or disability. Next slide.
This is it.
Okay, so what they did was a survey to understand the prevalence of microaggressions. It was distributed to the online Women in Orthopedics group, and it consisted of them detailing instances of microaggressions during each professional stage of their medical career, from residency through fellowship and attending status. Demographic information was collected based on subspecialty, location of residency, fellowship, and current practice, and it was based on personal experience. It was to identify perpetrators within the clinical setting. Next slide. So what they found was really interesting. 92% reported experiencing some form of microaggressions. So over 90% of the respondents. 60% were identified as patients or patients' families as being the aggressors or the perpetrators of the microaggression. That was then followed by 59% being from male surgeons, and then 56% from female support staff as the two most common perpetrators. There was a statistically significant difference in the score based on career stage. So residents were most likely to experience all forms of microaggressions. Residents experienced microaggressions and physical barriers more common than fellows and attendings, and age, race, demographic region, and specialty didn't really increase the likelihood of experiencing a microaggression. Next slide. So I think the take-home points is this: microaggressions are experienced by 90% of women from residency to attending status. Residency is going to be the time that a female orthopedic surgeon is most likely to experience microaggressions. And the most common perpetrators are going to be patients and their families, followed by their male colleagues, followed by female support staff. As orthopedic educators, we have to acknowledge and identify and also help navigate these situations while maintaining a healthy relationship between the patient and their family, especially since we found that that was going to be the most common perpetrator. And then we have to actively engage in micro interventions, everyday deeds and words that can have a positive overall effect in creating an inclusive and welcoming environment.
Thank you. Julie, do you want to lead the discussion on this? Because you were very involved in this, obviously.
Yeah, I mean, so all surveys, let me put my video on. I mean, all surveys, have some weaknesses, obviously, inherently within the surveys. And obviously, some of the criticisms could be that, these are maybe some leading questions. But I do believe, and I'm sure all of our panelists can agree, we've all experienced some microaggressions. And for people that don't know what we're talking about, there are little comments that oftentimes aren't meant to be harmful, but they are harmful. Someone saying something against a certain race or ethnicity, or someone calling an instrument gay, or not even thinking about what they're saying, and really being harmful and hurtful, but sometimes not actually being aware of their harm and their hurt. Even, and I'm sure Dr. Bilbrew can, understand that people assuming that a woman or an underrepresented minority is not the doctor, that's a microaggression, and that happens pretty commonly. And so, this is something, what's challenging is that when this is coming from families and patients, that makes it hard because you want to have these good relationships with your patients and their families. And when they're the ones that are being the aggressors, it can be challenging. And so this is something that continues to go on a daily basis. And you might have the best program in the world that has a complete no tolerance culture, but you have patients and families that are being the aggressors. We're all well versed in the sort of the female phenomenon, in the operating room or in the hospital, where some of the female staff don't treat the female surgeons the same as they treat the male surgeons. These are all forms of microaggression. So, kind of a challenging topic. And I'd love to hear from some of the panelists on how they deal with some of these issues. Maybe maybe Sandy or Ron, either of you want to comment on, kind of how you deal in this situation. Let's say it's a trainee and you are there observing a family treating your trainee not with the respect you would expect from your colleagues or their colleagues.
Yeah, I guess I can comment. I usually address it right then. And sometimes if I'm not in the room and a trainee tells me about it, I find that a little bit harder to navigate. But I think honestly, with time and practice, it becomes easier to do some of those things and to make it clear that you expect respect from patients. And I've actually over the years had to do this for my support staff too. So my medical assistant, is frequently the source of, or frequently the target of abusive behaviors from patients. And I've talked to patients about that too. And it usually, I think handled in a delicate way works out okay. I don't, I just am sort of firm and businesslike about it, kind of no nonsense and don't linger on it, but make it clear.
Yeah, hey, Julie, I agree with all that Sandy said. I think at times I try to bring the patient or the nurse or whoever or the physician who may be providing the microaggression another another way to perceive what has just happened and understand that it could be taken differently. And also if they just think that they can say these things because of the person's relative position to them in their world, I remind them, if they have so much respect for a person like be that person as well. And sometimes it makes them realize, that we're all in this together. I mean, to be honest, there's times on the floor where people will come up to me and ask me questions as if I'm the nurse too, if I'm wearing scrubs. So I think it happens more than we know. And I think sometimes I just try and use humor. I say, no, I'm just the lowly orthopedic surgeon. I have to get the nurse who can really help you with this, and that sort of thing. And that may make people pause sometimes.
I'd like to add a comment from, so sorry, Lisa, I just want to add a comment from one of the med students on. She said that as a third-year medical student, I have almost exclusively had microaggressions from patients, not from attendings. I was in a clinic when a very obvious microaggression was thrown my way. The male attending did nothing, but the female nurse in the room corrected the patient. It was so comforting to see another female had my back, and I teared up from the support. So, I mean, that support is critical.
I was going to add that, I'm in my 5th year of practice here. And what I teach, it's funny, I just spoke with one of my mentees about the same exact thing, who's an intern in orthopedics. And it doesn't get easier to experience microaggressions. We, especially coming from the perspective of a Black woman in orthopedic surgery, it's like death by 1,000 cuts. There's no point in my career where I'm going to be mistaken as, a janitor or have a microaggression from a patient and not have it hurt. I had it happen today in clinic. One of the techniques that I have been teaching my mentees is acknowledge it. So, my patient was looking at me and through a mask and glasses, completely skeptical. And I said, I'm concerned that you don't believe what I'm saying. When you hit it on the nail like that, then I was able to open up a discussion. Well, actually, doc, yeah, and it came out. And then I was able to address clinically the problem. By the end of the visit, there was a camaraderie or a relationship established. But the first thing I want for any students or residents or even fellows that are on the phone, I don't think it gets easier. I just think that you equip yourself with a toolbox on how to handle it. I also think, as I'm thinking about the conversation I had with the intern today, who I guess maybe came off a little bit flippantly to the patient, is that that is our defense mechanism often, and the response was, did you go to medical school? Not appropriate to say that to a patient, but I understand the pain of thinking, I'm going to experience this today and probably even my last day as a practicing orthopedic surgeon. And when you carry that pain to say, they will the world will always look at me as not the doctor. It hurts. As educators, as leaders, and I'm in private practice, I'm not in academics. I think it is important to recognize that. And I think the ownership is, like Lisa said, leading from the top down to make sure that we know that we have to cover our residents, our students, and our fellows as they go through the training process.
Very well said, Lattisha. I think it's really important. Until you walk a mile in someone else's shoes, you don't know what they've gone through. And you brought up some excellent points. I also want to give a hint to everybody. I think that we should be introducing everyone in the room as part of our team. You know, don't just let people follow you into the room. Introduce who's part of your team, so that once they see you're part of the team, that also, you know, encourages the patient to treat you that way. All right, I think we can move on to the next article. That was excellent, and we'll be covering that more in the discussion. Our next article is from JOS, the training room. Dear Program Director, solutions for handling and preventive abusive behaviors during surgical residency training. Arianna Gianakos is going to present this article.
Thanks, Lisa, and thanks, Julie, for organizing this. It's been a really great discussion, very important topics we're covering. I'm very honored to be here. So yes, I'm presenting this article. Basically, we know that the prevalence of these abusive behaviors, based on all of the literature that has been reported in the last several years, have demonstrated alarmingly high numbers. A lot of these behaviors are experienced by residents, and these include bullying, discrimination, harassment, sexual harassment, retaliation. A lot of the times, residents, you know, in a junior position are very scared to report this because they do fear retaliation and detriment to their career. And a lot of this is due to the lack of a good reporting process. And next slide. So the Speak Up Ortho campaign recently raised awareness on the prevalence of this. And in doing so, we decided that it was important to raise awareness, but more importantly, we needed to determine how to make a difference and be that change in order to make the environment better and more conducive for our residents. So between March 2021 and May 2021, 200 orthopedic residents submitted stories, and these demonstrated the top 5 common behaviors of sexual harassment, bullying, harassment, sexual discrimination, and microaggressions. In that, we found that the most common perpetrators included attending physicians, senior residents, a program director or a chair, a nurse, and then a patient. Most of the individuals who had written to us had written that they did not report to an institution due to fear of retaliation. So the aim of this article was just to provide an overview of some ideas of how to address this. Some of the solutions we came up with and developed were, first of all, changing the entire culture of a program, and that starts from the top down. Leadership can really dictate how the program runs and functions and can dictate the personality of the program. We need to be better at defining and educating our residents and faculty and staff on what behaviors entail and make up, you know, bullying or harassment, you know, or you really define this so that there's a real clear understanding of what's going on and what an abusive behavior entails. We need to start developing codes of conduct in our systems. Just discuss a little bit more about Title IX mandatory reporting. There should be confidential reporting processes that are also instituted. We would like to see more often than not a designated resident advocate or a third-party professional that's involved, as well as an ombud. We should have defined consequences when someone is accused, and then when an investigation is performed, if they are deemed that this had been going on, we need to have defined consequences for the perpetrators. We also need to focus on how do we support our victims. We hate to use the word victim, but unfortunately, a lot of these behaviors are a type of psychological warfare, and it's important that we provide help to those, whether it be counseling or just someone to talk to that's within the hospital system. Some curriculum changes are very important, such as bystander intervention training and other types of educational simulation training. And then we should also be vetting our leaders and vetting who is faculty, who's on staff, and who's the heads of a lot of our different societies. And that's it, Lisa.
Yes. So now I know there's been a lot of questions coming in, and the question, Julie, would you like to cover some of them and ask our panelists?
Sure. So I'm not seeing any active questions in the chat box right now, actually, Lisa.
Oh, okay, that's fine. Well, then we'll start our discussion. So Arianna, how do you think attendings and residents can be educated on how to prevent these behaviors?
Yes, so as discussed before, I think first and foremost, it's really important that we define what behaviors qualify as bullying, sexual harassment, discrimination, and so forth. Open dialogue is really important, and that helps us shift the culture from one where reporting and discussing issues is looked down upon to a culture where actually bringing up these concerns can be embraced and people can feel supported. And this can really help make all the difference in preventing perpetuation of the conflicts. I think education curriculums before people start and then throughout the time during training is useful, but particularly not one that you just click through, when you're doing your training, like an EPIC training. Particularly you need ones that are more interactive amongst residents and faculty. We do have already a bunch of different types of bystander intervention training protocols that are out there. That's a great resource because it really does involve open communication during the simulation trainings. And then I also think it's important, and I know Sandy had touched on this earlier, that we need to provide information to our trainees as well as our faculty on how to report and where to report and how do we do this in a confidential and safe manner.
So one final question for you. What are some of the emotions you think someone who reports abusive behavior experiences?
As I had mentioned, I do think that sometimes individuals who do face these types of behaviors almost experience a type of psychological trauma. A lot of the time, this can be accompanied by self-doubt, a lack of self-confidence. You can start questioning yourself. You question, you think maybe it was something you did. What did you do wrong? And it can be very isolating sometimes. And ultimately, as we mentioned in some of the other articles, this can lead to depression, anxiety, and it also causes a lot of people to face burnout and want to drop out. I think too, especially when you're in training, you can be incredibly scared on how it looks when you are reporting and bringing up a concern. This is not easy for someone to talk about in general, and then having to go to an authority figure can be really difficult. You might be scared that you might be deemed as weak or vulnerable or like a whistleblower or a problem person. But I think we have to remember that in general, it's really difficult to stand up for yourself in this day and age, although I think platforms like this and journal clubs like this are now making this a little bit easier for everyone to realize that there's a support system out there. But I think when someone does stand up and say something and report something, it needs to be taken very seriously because it is difficult in that power dynamic to do it. And so the institution should recognize that and should really listen and make that person feel that they're going to be believed so that they are validated in what they're saying.
Thank you very much for covering this difficult topic. We have one final article for our journal club discussion. Jennifer Weiss is going to discuss this specialty article, which was in JOS on Speak Up Ortho, Narratives of Women in Orthopedic Surgery. Go ahead, Jennifer. Jennifer, is your microphone on? Yeah, okay. Jennifer, we can't hear you. So what I'm gonna do until I know Jen just interrupts me when when we get this technical error. Oh, got it. Okay, go ahead.
Can you guys hear me okay?
Yes. It's breaking.
It's not great, Jen.
Hear me, Lisa?
I can hear you, but it's really difficult. Try one more time. Okay.
Okay.
So
I'm gonna text you.
Okay, so what we'll do is we'll go through this. Julie, why don't you go through this article, and then we'll get to questions.
Sure. I'm going to ask one question while we're waiting to see if Dr. Weiss can get back on. One of the questions was, can the ACGME mandate every residency program to notify residents on procedures for reporting, and also having a standardized training for residents and faculty? Can Joint Commission institute this as well for all the staff? We do have a mandatory training at the VA and in this individual specific medical group.
I think that right now that's not instituted yet per ACGME or any of the overseeing bodies. Something that we are, with our Speak Up Coalition group, that we're actively working on is trying to develop strategies that incorporate overseeing bodies and governing bodies to standardize what is required as far as educational curriculums, and exactly what the question asked, you know, where do you go, how do you go, what's the system? And we want to make that standardized across institutions because unfortunately not every program is created equally, and the way the leadership falls and the culture and how things are reported, that's also not standard across institution. So that is something we're actively working to create basically a policy, and whether that is done by ACGME or ABOS or something like that, we're in the process of talking with them to figure out what the best way to tackle that is. But it's a really great point, because I think part of the issue is the lack of standardization across the country and how this is being managed.
And for those of you that don't know, Dr. Gianakos has been really, really out in front, along with Dr. Weiss and others, as well as Dr. Cannada, to really try to take this to the highest level. So, I mean, this is the questions that are being asked, and just so you guys know, on the panel, there are other questions being asked along these lines as well. Why is the onus on the victim? Why is it on the, lowest person on the totem pole? Why is this not like a universal thing? And that is sort of the goal of this group, is to really push the envelope. We've been speaking with the ACGME, as well as sort of leaders in the sort of educational realm. So this is a hot topic, and one that needs to be addressed, and we're not there yet.
We continue to work every day. I believe, and I also want to call out ABOS, as we were able to provide 2 of these articles in this journal club as part of the WLA this year and write questions on it. So all of you who are board certified or going through the board who are already board certified and going through a WLA, the ABOS has listened and gave us this opportunity. I believe Jen is back on, and we'd like to let her do her article.
Awesome. Can you hear me now?
Yes.
Yay, 3rd time's the charm. I am going to skip through the introduction because you heard about the inception of Speak Up Ortho from Dr. Gianakos ahead of me. This article was a accumulation of narratives, and what we did was we put together some narratives, and then the authors all got together and described the groups or the groupings of the narratives. And I just want to take this opportunity to read to you some of these narratives. I won't read them all, but I will to give you an example of the microaggressions. I will read you narrative number 2, which is, one incident by itself isn't horrible, and I can tolerate a lot, but microaggressions accumulate, and when they happen repeatedly, it really takes a toll on you. They affect your confidence and lead to a lifetime of imposter syndrome for some of us. So we heard from Dr. Bilbrew earlier about the fact that she
Jennifer, we've lost.
Like she's going to feel this till the last day of her career, even though she's only in year 5. That is such. And then next slide, I'm going to give an example of a. Can you hear me again now or no?
Yes, you do break up. Here's the next slide on.
Lisa, if you can hear me, just have somebody else give the slides. I'm sorry, I don't know what's going on.
No,
with
that's
my
fine.
internet.
I'll go through this, and then we'll ask questions. So in this was narratives on bullying and harassment. And we're going to discuss narrative 2. As a junior resident, I was harassed by a more senior co-resident. This escalated to stalking me at both work and at times following me home. I was afraid to go to work and to go home, fearing he would show up wherever I was. Eventually, my institution found out what was happening, and when I had to sit in front of my program director and assistant program director, I was told, just stay away from him and it will be fine. We can't make him not graduate over this. Imagine how that would make the program look. There we have an example of nothing being done. In an example of sexual harassment, of all the things we talk about, discrimination, bullying, harassment, and sexual harassment is a crime. And that's the important thing. Narrative number 3, as a resident, I was asked to show a visiting professor the way to the conference banquet. I was alone in the elevator with him. He wrapped one arm around my waist, slid the other hand up my skirt and hissed, "Now who's a strong orthopedic surgeon?" I pushed his hand off my butt just as the elevator opened. I never told anyone, but every time I ran into him at conferences, I would shake uncontrollably. In an example of discrimination, this I'll read narrative 1. In our residence selection meeting, which included 25 to 30 attendings and chief residents, of which I was one, in 8 months postpartum, the chairman of our program announced, "We cannot risk matching another woman because, you know," gesturing at the one that was postpartum, "I was the only woman in the entire department for the duration of my residency and the first to dare have a baby." A normal life function. And there's examples of retaliation. And I'll read narrative 5. I spent 3 years reporting mistreatment to my chair, to the Dean of Faculty Affairs. Multiple female faculty from my department at the time reported similar issues. Nothing was done. The mistreatment escalated. The only option for a strong woman with her values intact was to leave the institution. I learned a lot about the priority of the institution. The process was protecting white male leaders at all costs, and retaliation is inevitable. So in summary, this article described these narratives. It's unacceptable behavior, antiquated behavior, and a risk not only to the physician, but the entire community, including our patients. Safe reporting structures with action and accountability are essential to keep our profession safe and relevant. Thank you, Jennifer, even though you weren't able to present your slides, for preparing these on this important article. We're going to open all panelists. Please open your video and microphones. And Julie, you can start the questioning from the chat box.
Sure. So one of the questions was, whereas sexual harassment does have a mechanism for reporting through Title IX offices, racial discrimination does not. How do you suggest these issues are addressed with the same level of scrutiny and attention?
Ron, how about you? And yeah, Ron, address it, and then whoever else spoke up. Go ahead, Ron.
It was from the chat there. Yeah, whereas sexual. How do we suggest these issues are addressed? I mean, a lot of this is governmental and political, and I think these are grassroots efforts. I think the very work that is being done through Speak Up Ortho and these salient and really seminal articles that are really highlighting this are frankly alarming and are the first way to go about this. I think that we in orthopedics as a profession through the AAOS and our orthopedic pack, we need to be speaking to people on the political side to kind of make change occur in ways that this question is really focusing. That you know, off the top of my head, that's my first approach. You know, get it out there and try and find advocates and allies to kind of help take things forward and make change.
Lattisha?
Yeah, I was going to add, I think one of the most important steps is finding an ally and understanding that if you're the only one that is experiencing that in a program, you may not find an ally in that particular program. But, you know, things like this is great because you have the panelists that you could reach out to and find a mentor. I also think documenting it, you know, when you do experience it, writing it down so that you recall it is important. And when you're in a position where you don't feel like you have a voice, let's say you're an intern and you're like, well, you know, I just got in this program, or even if you're a fifth year, coming with an ally into the meeting is important. And I think that's where it has to start. You have to actually open up and tell someone. One of the things I saw in common with these articles is that oftentimes it's not reported. And it's hard to report if you think that there's an institutionalized approach to it. So find somebody that you can speak to, reach out to people through organizations such as this, and just discuss it. Start there.
Lisa,
Arianna.
I just to add to that, I think that I totally agree with Lattisha and Ron on what they're saying as far as the first steps. I think that unfortunately, Title IX reporting is different based on institution, which is where people run into problems. So although we might know that this is a valid thing and that this is not supposed to be tolerated, I think it's not necessarily a safe spot for a lot of people, and they don't feel comfortable doing reporting through that system and channel. So in regards to using something similar to address other types of behaviors, whether it be racism or microaggressions or whatever it might be, I think that this is where some of the work that we're doing, what we need to focus on is really truly changing the system to make it standard across the entire country, so that if someone does need to go to a quote Title IX or some sort of reporting channel based on what behavior they're reporting about, it goes through a system and a protocol. And like Lattisha just said, it's a system that people are confident that they're not going to be just brushed aside. But I absolutely agree with having an ally and having someone to sit and any kind of bystander to help, and documenting everything is the first steps. But I think we need to actually change the system because unfortunately, with Physician Just Equity, the group that we're in, we see a lot of people who go through Title IX, and it's unfortunately not very helpful for them.
I would like to offer something up that Bird Nichols offered the group. It stated that the EOC office technically should enforce the Civil Rights Law of 1972, which prohibits discrimination on race, but are typically thought of as Title IX offices. The EOC office is typically what institutions have, the Equal Opportunity and Compliance Office, but agree with all the answers on the panel. Grassroots level and finding mentors is really one of the best ways.
And Julie and Lisa, as you know, I'm hearing this too. We have to acknowledge beyond Ruth Jackson, because this is a race discrimination question at its heart. There are great organizations like GLAD and the American Association of Latino Orthopedic Surgeons, to name two, that maybe are other ways that organized groups can help advocate and bring, and maybe we can go back to them as an offline work to kind of say to them, can you consider taking on issues like these? So beyond what's done at the location and the rights that the wrongs that can be righted at the location, there's organizations, I'm a member of AALOS too. These organizations can potentially be a conduit for help too.
Thank you.
I completely agree with that. I have 4 mentees that are combination Black men and women that are currently on remediation within being an intern or a second year. 4. And I just think it's ridiculous that's crazy to me. Like how can all 4 of them be that, excuse my language, piss poor? And as they tell me the microaggressions and the biases that are present, as a member of RJOS and Gladden Society, I think it's a great idea that we need to go back and really target on the re-education of people in leadership positions to be able to stand up and advocate. And if they're not going to advocate, at least recognize that they may be intentionally or unintentionally participating in biases that are potentially destroying people's career and not creating a nurturing environment for these future orthopedic surgeons.
So Lattisha, you brought up two groups, and I do want to mention, you brought up RJOS and J. Robert Gladden Society. They're part of the Board of Specialty Societies, of which there's 23 specialty societies. I just want you to know we are working with the BOS and BOC, and it was actually through a discussion with the BOS Diversity Task Force that this opportunity to have this webinar came up. We are working to definitely make sure we hit all groups so that no one is left behind.
I would like to bring up a story that Jo Hannafin posted. She stated that a medical student that was interviewing for residency called her after an interview. The chairman of that program spent the entire interview discussing the interviewee's clothing, like how did she decide what to wear, what was her social life, how did she meet her husband, and other very personal questions, which everyone on this panel and hopefully everyone that's listening knows that that's absolutely not legal. The faculty member obviously was not at Dr. Hannafin's institution, and she wants to know, is there a path to report to the ACGME while also protecting the student? And Kristen Russo answered below, I have contacted the ACGME for a very similar occurrence and was told they have nothing to do with interviews. So how do we protect that student who, obviously she's not going to match at this program. She doesn't want to rank that program where the chairman is absolutely inappropriate. If it comes from the top, then that's not a place where you want to train. But how do we protect the next student that goes to that program?
Honestly, just to kind of make a comment on all of this, our reporting structures and our ability to protect these students are only as good as the institutions within which they reside. And so you can have all kinds of policies in place, but if the culture of the institution is that things go unreported, these behaviors are tolerated, then it's just going to continue. And, it is a leadership thing. It comes from the top to create a culture that is supportive, inclusive, and equitable for residents and faculty, quite honestly, as well. And so, the focus really, I think we all need to take is like our own playground, so to speak. You may not even be able to change your institution as a whole and how receptive they are to reporting or taking care of these issues. So you got to focus on your own department. It's got to be intentional. It's got to be an effort that you make every single day. And it's got to be a top priority of the leadership without taking a break. There are no vacations from handling these issues. It's got to be done every day.
I'd like to bring up a comment that Dawn Laporte, who's the program director at Johns Hopkins, stated. She stated to Dr. Hannafin and Dr. Russo that the violations of the match code should be reported to the NRMP and also the dean of that institution. So if something like this happens in the future, the NRMP should be where this should be reported, and then again go one step above that chair and report to the dean. Is her recommendation.
Thank you. That's a great point. And also at the institution level, the DIO, the designated institution official, is also another resource at the institution. Julie, what other questions do we have?
Yeah, this one, can you hear me? I like this one. Can the panelists give examples of phrases or specific responses when faced with, in the moments, with microaggressions? She states that often when the amygdala hijack happens, you sort of lack the words to navigate that process. So it was brought up in one of the earlier responses in the chat. I'm often like, if someone says a joke that's a totally inappropriate joke, I will ask, oh, I'm sorry, how is that funny? And even just asking, how is that funny, brings an awareness to the, oh, maybe that was inappropriate to the person who gave the joke. That's kind of that's what I do. I ask questions. What do you guys do in the moment? When maybe let's pretend that you're on the bottom of the hierarchy. What do you say to someone above you and still, keep that respect?
Julie, you bring up a good point. There's something that we are pushing, and we'll offer a training session the end of this month, bystander intervention training. You brought up a great way, and that is distracting them. You're asking them, how is this funny? There's 5 Ds of bystander intervention training, and one of them is distract. You did that. Another way to distract is dropping something on the floor, dropping a drink, you know, or tripping, even anything to draw away attention from what is going on. You can directly address it. You did directly by actually asking them, why did you think that's funny? But it also distracted the situation. Delegate someone else to be in charge. Delay. And with delay, we always ask that you ask the person involved how they were affected by it, and document what happened. So those are some, you know, there's our techniques. We are going to push this. Our goal is to have bystander intervention training on your badge at every hospital or institution, so that you have the 5 Ds and you have examples of the 5 Ds. We will, on February 28th, have 100 spots open. I know there's more than 100 people on this, and there's a lot of people involved. Please send your name and we will fill up the 100 spots for sure. And what are ideas that other people have on the panel?
I wrote in there that I paused for 5 seconds because I'm the same way. Sometimes my brain shuts down, or what I'm gonna say is gonna get me in real trouble. And so I try and count to 5, and it's amazing what silence does. And you just pause, and it's a long time. And then when I come back, I usually say, could you say that again? And I have a little smirk on my face. And so they already know that they've stepped over that boundary. But that's what I do. I have to wait because my mouth sometimes gets me in trouble.
A pause is a great suggestion. That is great. And also just asking them, as Julie said, to repeat, they have to reflect on their behavior. And what, Julie, do you have some more questions for us?
Yeah, this is a great one. I would love to see what people have to say about this one, because I feel very strongly about this this issue. How do we address the lack of confidence that some patients may have about either a female surgeon or an underrepresented minority surgeon? I'm going to task Dr. Bilbrew to answer this one. How do you give your patients the confidence when they don't think that you're even a doctor?
You speak confidently. That's how I give them the confidence. I am 5'4" and I don't look like a doctor according to the world. But when I walk in a room with my shoulders back and my head high, or sometimes when I'm just walking down the hospital hallway, I've had people tell me, you must be a doctor just from the pace that you're walking. When I speak to my patients, I speak confidently about their diagnosis, their prognosis, and their options. And I speak with empathy and kindness. And that is going to get 99.99% of my patients. The ones that don't, it's because they are best friends with Hitler. Like there is something extraordinarily wrong with them. But otherwise, if you speak as if you know what you're speaking about, and that you are confident that I am the right surgeon to take care of you, that's all patients really want. And I think we have to remember the core that no matter what, patients are hurting, right? They're coming to you because they're in pain. I have to remove any societal or cultural issues that they may have with the way I look and address their pain first. That is the first reason that they're there to see you. When you put that at ease, then they'll trust you.
I would like to add, though, also have a low threshold. If you get that vibe that this is not a good doctor-patient relationship, give them an offer for a second opinion. Send them to one of your senior partners. Send them to someone else, someone that you trust, obviously. Because if you don't have that good rapport, like you just have that feeling that something's off, it's a wiser thing to send them on to someone else that can either say, oh, Dr. Bilbrew's amazing, or Dr. Cannada's amazing, you need to go back to her. But if you don't get that good vibe, then the risk of proceeding with any sort of surgery or management is higher for litigious approaches.
Okay. Do we, there's some, Joey Hannafin came up with a great comment, always introduce yourself as doctor. And I have had patients ask me after extensive surgical discussion, will you be doing my surgery? And my response is, I am prepared to do so. The response is usually positive. So you brought up a good point, and being confident, looking them at the eye, introducing yourself and every member of your team, and then re-emphasizing that in the room is also something that can be helpful. Julie, what other questions do we have?
Yeah, I love this. I'm gonna call out this guy's name. Matt Schultz is a white man hoping to match into orthopedic residency this year. I want to be part of the needed change in our field, but don't know what that looks like. Any advice on how to be an ally? And I would, I'm sure every panelist has a great advice for you. But even just you speaking up, if you see one of your co-residents who's a woman or an underrepresented minority having some interactions with either patients or families or staff in the room that is not appropriate, you can use your voice and say, that's not appropriate. Please provide my colleague with respect. Introduce your colleague as Dr. So-and-so. If you see something, you're speaking up, it resounds. That's sort of my advice. Anyone else have advice for our up and coming orthopedic surgeon who wants to be a part of the solution?
I think in residency, at least in my N of 1 residency experience, every year they kind of pick the underdog. They pick the person that they say is not the good resident or not the good intern. And it typically tends to be someone who is in an underrepresented group, if there is one in there. One of the ways you can be an ally is that when you hear people speaking negatively about that intern or resident or fellow, that you come against it and you speak positivity, right? And then when you get in a position of power and authority, for example, like when you're in a chief or an attending or a fellow, that if you see that they're lacking behind in some skill set, that you potentially take your time to mentor said person. Sorry, my kid just walked in. That you take your time to mentor them and to really help them where they may be struggling. Those are my examples. And I just got distracted. So go ahead.
No, Lattisha, you bring up a good point. It's great. We always want to cheer for the instead of joining in the bullying culture where someone is bullied, they already feel so alone, or someone is picked on or constantly questioned. When you see them alone, don't join and throw more sticks at them. Be a supporter, be an ally for them. Try to find the positivity in the situation, offer support. Sometimes you may be their only lifeline.
I think that sometimes too, it may be difficult to recognize a microaggression or a harassment event if you're not tuned into those things, if you're not thinking about it. So again, the effort has to be intentional. And I think any female orthopedic surgeon who may be on faculty, wherever you match, or fellow residents who are females or minorities, will be happy to have a discussion with you about it. If you say to them, tell me about your experience, if you ask them, tell me about your experience, tell me what kind of things happen. What are the things that bother you the most? It'll give you some insight on how to support them. And that can be very meaningful.
I would like to bring one more question here from a 4th-year med student. She's curious about what a good response would be to unwanted touching. The example she gives was she was talking to a rep in the OR when he asked what specialty she was interested in, and she replied, orthopedics. She was standing with her arms crossed, and he went ahead and squeezed her biceps, and she was in so much shock she stepped away, but she didn't say anything, although she wished she had. What would the response be in that situation? Anyone on the panel? Arianna, maybe?
Sure. Yeah, so, I think that any form of touching in the OR is likely inappropriate. And something I've learned through my own experiences, I used to be very quiet and I wouldn't say much because, you don't want to cause a problem or make something uncomfortable, because raising that could cause an issue between you and the person who might be touching you, even if it was unintentional to make you feel that way. So I think first and foremost, I like to believe that most people don't have any malintent. Obviously, there are some bad eggs, you know, in the lot, but for the most part, no one wants you to actively feel uncomfortable. So I think that it's very reasonable if you pull the person aside, if it is something that made you uncomfortable, one-to-one, you know, not where you have any people standing around to listen in on the conversation, and just be very upfront with them and honest, and just say, you know, listen, I'm a resident or I'm a faculty member, and I deserve the respect. I've worked really hard to be at this level. When I come to work, that's work. And while you and I are friendly and we're cordial, I deserve that level of respect that you would give to one of my male colleagues or anyone else. And as much as I know we're friendly, the way you touch me in the OR makes me feel uncomfortable. I know you're not intending to do that, and I know that you're just joking around, or whatever, however you want to word it. But I think just an open dialogue as the first step is key, because I think a lot of people don't realize what your comfort level might be, and if you draw that line right away, but you do it in a way that's not, you know, putting them on the defense initially and giving them the benefit of the doubt, normally they'll respond appropriately and they'll stop. Obviously, if this continues and they're not listening, you know, you might have to escalate that and have other people who are witnessing and documenting that. And hopefully that doesn't get to that level. But I do find that in most cases, if you can have just a very professional one-on-one conversation and give them the benefit of the doubt, you know, touching a bicep, they might not think that's much, but at the same time, that can progress. So you nip that in the butt right away, and you've already set your boundaries in a very professional manner.
Great. You know, we want to thank the Ruth Jackson Orthopedic Society for sponsoring this journal club. We do have a packet. Like we said, we want to get to all the residency programs. We'd like to thank the attendees. In wrapping up, I'd like to have one final piece of advice from all the panelists. I'll start in the order we did the articles. Sandy, go ahead. What's your final piece of advice?
Well, it's definitely hard to sum up all of these comments in one concept, but I do think that there's a lot at stake here for our specialty, and it's in the best interest of all of us, men, women, doesn't matter who you are, to make an intentional effort to stop bullying and harassment within our specialty. And I appreciate everybody who's on this webinar being willing to make the effort. And hopefully we can convince all of those many orthopedic surgeons out there who aren't on this webinar to do the same.
Thank you. Ron.
Yeah, you know, I think just in a general way to kind of bring Speak Up Ortho into more discussions, these stories and some of the ones that you just read, Lisa, while covering Jen's article, they are alarming and sickening, and they touch people's heartstrings. And I'm so amazed at how many people still don't know about this movement and these anecdotes. And I take every opportunity I can to say, have you heard about Speak Up Ortho? Have you read the stories? Just go read the stories. And it moves people. So we all have to be apostles, if you will, to continue to talk about this so that it gets out there, because most normal human beings do not find this acceptable. I have to believe that most people are good. And so I'm just going to do everything I can to continue to shine a light on what's happening.
Thank you, Ron. Lattisha.
I guess my last bit of advice is more so an affirmation that you're qualified to be here, that if you decided to become an orthopedic surgeon as a student or a resident or a fellow, you deserve to have this training, and don't allow the situation to rob you of that pleasure. So you're qualified is more of a statement.
Thank you. Arianna.
They're all great statements. And I feel like every time we have these webinars, I learn something and feel better about everything going on too. And I think to leave this webinar tonight, I would say first and foremost that whatever you may be going through, you're not alone. I think that the fact that we're able to have these types of open dialogues and discussions and a journal club, and now, you know, we're talking more about doing lectures in institutions. I think we now are in a place that the culture is shifting, and it is more acceptable to talk about these problems so that we can provide support. So if you're ever going through something, you know, you have all the panelists here as well as all the various amazing organizations, you know, that are with the BWS, Gladden, all across subspecialties. You have people that are going to be there to support you. So I think you should just remember to utilize that because you're not alone. And my second piece of advice, which is just piggybacking off of Lattisha, is you are capable of doing this. And if this is your dream and this is your goal, it doesn't matter, you know, your personality, what your background is, what your beliefs are, it does not matter. You bring your own superhuman strength to the field of orthopedics, and you should always stay true to who you are, because that's what's going to make you shine in this. And we welcome and want a diverse background. So never change just because you're trying to fit the mold. We're trying to change orthopedics so that it now is a whole different, it's a whole different perspective than it ever was before.
Jennifer.
I'm hoping you can hear me. First piece of advice is do not rely on Wi-Fi when the power is out. And second is, more importantly, trust and pride. So I'm really, really incredibly proud of our orthopedic community. When we started Speak Up Ortho, I had the trust that it was going to be received well because of the way we were constructing our message with a
Jennifer, we lost you. Julie Samora.
I was waiting for some real pearls there, Lisa. Sorry, Jen, that we lost you again. I think what everyone has said is absolutely truth. I think it's important for us to find our posses. If nothing else, find that person, find your family, find a partner, you know, find a colleague that can be your sounding board. Maybe something happened that you aren't sure really happened. Run that by somebody. Find your people and speak up. As much as you feel comfortable, depending on, you know, where you are in the hierarchy, how comfortable you are in the situation. If you have the opportunity to speak up for others, that is hugely significant. If you have the opportunity to speak up for yourself, I understand there's ramifications sometimes, and hopefully we're gonna, you know, solve that problem, not anytime soon. But find those people that can be your support network, because this is hard. And, you know, all of us here are more than willing to be a sounding board for you.
That's true. And in closing, I'd like to say thank you to everybody. And my entire career is dedicated to making the path better for those that follow. And this is part of it. Thank you again.
Good night, everyone. Thanks for joining us.